I hope that was helpful, talking about prescribing in pregnancy. The next section of this presentation is prescribing in breastfeeding. So I'll just start talking a little bit about that. But the most important thing to understand here is that we've got another barrier, which is fantastic. So now we've got the drug has to get not just into the maternal system, but into the maternal milk system as well. We know that breastfeeding is absolutely beneficial. It's helpful to the fetus, to the developing, sorry, to the neonate and to the developing child. From an immunological perspective, we know that children who are breastfed are far less likely to be obese later on in life. They're far more likely to have less asthma, less respiratory diseases and conditions. And we know that nutritionally it's the right thing that these babies can be having. The NSF suggests that breastfeeding has both short and long-term health benefits. We know this, and we know that we have these sort of standards frameworks that are suggesting that we should all be encouraging breastfeeding in our ladies who are pregnant, in the people who are pregnant. So we've already talked about the pharmacokinetics of any medication, being absorption, distribution, metabolism and excretion. Now when you're thinking about prescribing for a breastfeeding mum, we have to now then think about that drug not only being absorbed, distributed and metabolized in the mum, but we have to think about that then being metabolized into a form which would be soluble within the breast milk, and then that very, very thinly concentrated dose in the breast milk being transformed to the neonate or the baby, and then the infant absorption, distribution, metabolism and excretion mechanisms as well. So already we've halved, quartered, we're reducing the amount of medication that we're giving to the mum by such an extent by adding another barrier. So we've no longer got the placenta and that barrier, but we do have the breast milk and the breastfeeding barrier. So the drug actually has to enter the milk, and it has to enter the milk in a pharmacologically significant quantity. And the concentration in milk of some drugs can be really quite high. Others, it can be quite low. Some of them have massive effects, so phenobarbital, for example, will affect baby suckling and cause the babies to be quite sleepy. That has adverse effects because the baby won't suckle. Neonates and children need to make sure that enough milk is being absorbed and taken in to be able to grow and develop. So it's really important that you just identify what's going on. Now there are other drugs in the maternal cycle as well that can actually affect the ability to lactate. So if you start to prescribe a lady who is breastfeeding bromocriptine, for example, her milk will dry up, and that's going to cause a problem. There are other drugs that have theoretical potentials as well, to include sort of hypersensitivity to certain things. Even though the concentrations might be very low for a pharmacological effect, there's a potential there for hypersensitivity. So always be aware whenever a mum has been prescribed anything whatsoever, if you're looking at the baby and you're not quite 100% sure that something's going on, just go and ask around, refer back to the prescriber to see if there's any potential toxicity which may well be happening due to the prescription that the mum's received while she's pregnant, while she's breastfeeding. So some of the really common drugs that we really absolutely desperately do avoid. So antineoplastics will cause fetal death, will cause toxicity, organ system failure. So if your woman who is breastfeeding is desperately needs these antineoplastics, then we would consider moving on to to other sort of forms of food. Immunosuppressants, something similar as well. They will cause immunosuppression in the child. Lithium can be toxic. It can also reduce the child's ability to suckle. They'll be very tired, lethargic. Chloramphenicol is one, not necessarily in the oral route, but chloramphenicol with some of the child doses can identify serum dyscarrias, aplastic anemias. Many of the ergot alkaloids can cause poisoning. Many of the radiopharmaceuticals might well suppress prolactin and therefore the ability to be able to produce milk in the first place. And then iodides as well can also cause thyroid suppression in the babies when they're breastfeeding. So basically the question is, it's just, you should never be prescribing anything for pregnant or breastfeeding ladies unless the risk outweighs the benefit. If you've got a woman who is desperately in need of radiopharmaceuticals and some sort of investigations and orders, then you would do that. You would just look at alternatives and you discuss these with the mums. So I've already talked about pharmacodynamics of the drug in a breastfeeding infant as well, and how it first of all has to come through to through the breast milk into the baby at a dosage which is therapeutically going to have an effect. But what you have to think about, I mean, does it still remain bioavailable? Because that drug's now got to get through the maternal circulation, the maternal lactation, and then through the infant's absorption mechanism, which is the oral route. So, we've got another barrier there. We've got an acidic stomach. We've got other things. The other thing to consider as well is, though, and this is pretty significant, is what sort of age is the infant? If you're feeding a 5-year-old child who's also taking a main diet, or a 3-year-old child who's also taking a diet as well as supplementation with breast milk, it's not going to have that much of an effect as it would, for example, a 28-week gestation baby who might well be, 1,500 grams, who is taking nothing but milk. So it's just about taking things into consideration. What are all the other confounding factors that are going on at the moment with this baby, the breastfeeding mum, and the medications the mum's taking. Other things as well are going to affect the infant's ADME, so the infant's pharmacokinetics. So things like prematurity, jaundice, allergies, potential adverse drug reactions that are based on genetic factors. There's a number of individual attributes which will also affect how well the babies can actually manage and tolerate whatever side effects that could ensue. So why do we prescribe medications while women are breastfeeding? It's an interesting one, but quite commonly we do see a number of infections that happen during that neonatal and postnatal period. So for example, women who are just getting on with breastfeeding, they may well have mastitis. There's a significant number of effects that happen post-vaginal delivery, so vaginitis, trichomonas vaginalis, especially in preterms. We could have an element of candidiasis, sexually transmitted diseases. So basically, when you are thinking about prescribing anything at all, just look in the BNF. Have a look to see if it does say precautions during pregnancy and breastfeeding. Don't use it. Refer to somebody else. You're not always the only one that can actually prescribe for anybody. This can always be a multidisciplinary approach. There's a number of other things as well that's quite common in maternal sort of period as well. So postnatal depression or antenatal depression as well. The good thing is that most selective serotonin reuptake inhibitors and selective noradrenaline reuptake serotonin and reuptake inhibitors, and most tricyclics as well, they come out in very, very low doses in breast milk after maternal ingestion. So it's always just a balancing act, and it's better that you've got a mum who is taking the medication that she needs to take, and you're balancing out your clinical analysis. There are drugs that do cause problems, as we've talked about before. So we talked about lithium, and we talked about a number of other things that will cause problems with neonates and children. So always just check. Always just have a look and consult with another healthcare professional if you don't know. The most important thing to remember is absence of information in the BNF, in the BNCF, in the MIMS, and all of the other types of drug formularies that you're going to do. Absence of information does not imply safety. Never assume, always think this might be a problem, and then talk to people, look for advice, look for information, get on the Teratology Information Service, use the Medicines Healthcare Regulatory Authority sites that you have, check the textbooks, and make sure that whatever you do, you only ever prescribe within your competence. And here's where I have to say, always remember your reporting schemes as well. So I used to work in the Medicines Healthcare Regulatory Authority as an expert advisory member for the Pharmacovigilance Advisory Group. It's utterly important that we do raise signals if there are continuing effects and side effects of certain medications. There's only one way we're going to find out, and that's by you guys reporting. So please use the yellow card scheme. Please feel free to access any of the European medical associations or the Medicines Healthcare Regulatory Authorities. Always have a look at different sort of safety information sheets, and if in doubt, consult with your local pharmacists, the consultants who are on call, and any of the GPs and regulators of, who will also there to be able to help you and support you with prescribing. Prescribing doesn't have to be a unilateral decision. It can be a multidisciplinary choice. And if you're in doubt, make sure that it is.